Thinking. All right. Hi.
Hi.
Hello, everyone. Welcome to Rocky Mountain Cancer Center's Oncology Watch on hypofractionated radiation. I'd like to introduce Dr. Marie Weeks. Dr. Weeks is a radiation oncologist with Rocky Mountain Cancer Centers in our Longmont area. Providing personalized and cutting-edge radiation treatment with compassion is her hallmark. For our viewers, we will be monitoring the comments section during Dr. Weeks' talk. So if you have any questions, please put them in a comment and we'll address them at the end of her talk. So we look forward to learning about hypofractionated radiation. Thank you, Dr. Weeks.
Thank you. Can you see the presentation?
Yes, we can.
So thank you. I'd like to talk with you today about radiation for breast cancer and specifically hypofractionation in breast cancer. So today we're going to discuss the who, what, when, where, and how of hypofractionation as it applies to breast cancer, not necessarily in that order. And then, as mentioned, there'll be time at the end for questions. So radiation is the use of high energy X-rays aimed precisely at a target in the body to help kill cancer cells. The standard treatment for early stage breast cancer after lumpectomy used to be conventionally fractionated radiation. And this is typically 33 to 36 treatments given daily, Monday through Friday. So you're looking at 6.5 to 7 weeks of radiation. So what is hypofractionated radiation? In hypofractionated radiation schedules, we deliver larger doses of radiation per treatment so that fewer total treatments are needed to get the job done. And whereas a standard fraction size is 180 to 200 centigrade, with centigrade being our unit of measurement in radiation, hypofractionation delivers 225 centigrade or more per treatment, depending on the cancer type. For breast cancer, it's around 267 centigrade to 385 centigrade per treatment. Why hypofractionate? Hypofractionated radiation therapy is given, again, over a shorter period of time, fewer days or weeks. So benefits, first and foremost, patient convenience. And this in turn increases patient compliance, also provides cost savings. Hypofractionation can help overcome barriers for women to even be able to receive breast radiation, like financial limitations or distance from a radiation center. How can this become the new standard? So to establish a new standard of care in medicine, we need scientific data that shows that the new treatment is just as safe and works just as well as the tried and true old standard. So I'll explain some of the data that helped us establish hypofractionated radiation as a standard of care for many women. But first, which breast cancer patients are we talking about here? Who, in other words, is a candidate for hypofractionated radiation? So candidates for hypofractionation include women with early stage breast cancer who underwent breast conserving surgery where the lump or the cancerous tumor was removed, patients with stage TIS, meaning in situ, T1 or T2, in 0, M0, for an overall early stage of 0, 1, or 2. Let's delve a little more into that. So to clarify those terms, we use what's called the TNM classification system. This will stage the extent of a breast cancer. T refers to tumor size in the breast, shown here in blue. Could be anywhere in the breast. N refers to nodal involvement, shown here in green, kind of draining the breast there. Has it spread to the lymph nodes or not? And M refers to metastasis. Has it spread beyond the lymph nodes into anywhere else in the rest of the body? And a breast cancer is classified as TIS if it's not invasive yet, T1 if it's less than 2 centimeters, and T2 between 2 and 5. So we're basically talking about tumor size less than 5 centimeters, without nodal involvement and without any distant spread. One of the largest trials and best trials comparing our standard long course of radiation to a faster course of radiation was performed by the Ontario Clinical Oncology Group led by Dr. Whelan. And their data was presented at ASTRO, which stands for American Society of Therapeutic Radiation and Oncology, back in September 2008. Their 10-year data was then published in the prestigious New England Journal of Medicine. And what they did was look at 1,234 patients, again with T1 or 2 cancers, under 5 centimeters, no nodes involved, and all patients had their cancer removed surgically with negative margins. Half of the women were randomly assigned that longer course of radiation, the tried and true, and then half of the women were in the experimental arm to try to get their treatments accomplished in 3 weeks. And they had excellent local regional control at 5 years in both arms, 96.8 in the standard radiation and 97.2 in the hypofractionated region out here at 5 years. This graph is showing essentially equivalent overall survival. So they definitely established the efficacy of the faster hypofractionated whole breast regimen. So what about toxicity, also known as morbidity or side effects? These researchers compared the cosmesis, meaning how the breast looks, both before the treatments and at different points in time. And what they found was the percent of excellent or good cosmesis was essentially the same, whether or not women were treated faster or slower. As I mentioned, they published their 10-year data, and as you can see here, excellent local control persisted for both arms. The United Kingdom also performed 2 large trials looking at the possibility of shortening the radiation course for women with early stage breast cancer. In the START-A trial, over 2,000 women were randomized to one of 3 arms, 2 of these arms being only 13 treatments, and then the standard arm highlighted in green. On the START-B trial, again, START standing for Standardization of Breast Radiotherapy, they narrowed it down to 2 arms, and this fractionation size of 267 is very commonly used today. So the START-A showed us, again, equivalent efficacy and only very slight non-significant differences in how the breast appeared at different points in time years out. START-B, again, showed essentially equivalent rates of local control, local regional recurrence, distant relapse, any breast cancer-related event, and all-cause mortality, with the numbers actually slightly favoring the hypofractionated arm in all categories, although none of those numbers were statistically significant. Severe toxicities were equal and very extremely rare in both groups, and those included ischemic heart issues, rib fractures, or lung scarring. So the American Society for Therapeutic Radiation and Oncology provided update consensus guidelines based on input from experts in my field and all of the available data. There's a lot more scientific evidence than just the 3 trials we discussed. With this update in 2018, the pool of eligible candidates for the faster course of radiation was expanded to include more women. So this includes now women of any age, any stage, provided the intent is to treat the whole breast without treating the lymph nodes. And whether or not women had chemotherapy, they can still get the hypofractionated course. And down here, dose homogeneity refers basically to how good of a radiation plan was achieved. And rather than keep a certain criteria, ASTRO now is simply advising doctors to aim for the best possible plan, no matter how we're fractionating the radiation. And of course, in my field, there are many published guidelines to help us achieve that for women with breast cancer. So in summary, hypofractionated radiotherapy is now the standard of care for eligible patients. The entire breast is covered. Typically 267 centigrade for 16 treatments is given Monday through Friday. The total dose to the whole breast is over 4,000 centigrade, and many patients do require an additional boost. That's usually given in 4, sometimes 5 treatments, and the grand total is generally 20 fractions. So in the last 5 minutes or so, I'd like to touch on accelerated partial breast radiation. We've discussed one approach to hypofractionation, which was to treat the whole breast over 16 to 20 treatments. But we also have data to support treating, just part of the breast, the lumpectomy bed, if you will, even faster. And so basically, we're targeting the lumpectomy bed where the cancer used to lie before the surgeon removed it. It's twice daily treatments for 5 straight days, 10 straight treatments. We give 385 centigrade a day. Total is 3,850 centigrade. And treatments are spaced about 6 hours apart. So for example, 9 a.m. and 3 p.m. And women are done in 1 week. So ASTRO also has guidelines for candidacy for this method of radiation. And the criteria are stricter than for whole breast radiotherapy, which we just discussed. So this slide contains many pathologic terms. And if you haven't watched Dr. Lori Jensen's talk on understanding your breast cancer pathology, I highly recommend it. She's a Rocky Mountain Cancer Center medical oncologist in Boulder, and gave a great talk reviewing all of these terms, from surgical margins to grade, receptor status, lymphovascular invasion, and how they impact treatment decisions. So basically, to be a candidate for the partial breast or 10 treatment regimen, women need to have a small cancer, less than 3 centimeters, node negative again, unifocal, meaning one spot of cancer, not several different spots. And the surgical margins, ideally, the surgeon has gotten around this cancer with a good 2 millimeters all the way around. Ductal carcinoma in situ, which is a stage 0 cancer, is eligible if it's a low risk. That means it looks fairly nice under the microscope, grade 1 or 2, less than 2.5 centimeters, and slightly wider margins required for that particular subtype of cancer. There is an age cutoff for the partial breast, and that is age 50. Now, women who have a genetic component to their cancer are still suitable for this type. Chemotherapy, want women who have not had chemotherapy for the partial breast. And invasive ductal, ER positive, no lymphovascular invasion are other criteria for this type. There are many ways to accomplish partial breast radiation. The most common and least invasive of these is external beam treatment. And this is what we offer through Rocky Mountain Cancer Centers. So there's also very strong evidence to support this type of breast radiation for women meeting all those criteria we just reviewed. The National Surgical Adjuvant Breast and Bowel Project Study Research Group conducted a large randomized scientific trial to establish, again, the safety and efficacy of this way of treating women. And so as you can see in group 1 or arm 1, they got about 25 to 28 treatments to the entire breast. 80% of these women actually did get this optional boost, making for about a 6.5-week course of treatment. Over in group 2, the partial breast radiotherapy, you can see again different ways to deliver this, and here our tried and true method. Again, 80% of the women on this trial were treated exactly how we do that here with external beam treatment. And once again, we're looking at our stage 0, 1, or 2 with small cancers on this trial. So what did they find? They found in 4,216 patients enrolled, basically equal efficacy and equal rates of severe toxicity. So once again, the Ontario Clinical Oncology Group also has published on this type of radiation in the RAPID trial, and RAPID stands for Randomized Trial of Accelerated Partial Breast Radiotherapy. They used 3-dimensional conformal treatment. They enrolled over 2,000 women. All women were over 40 years old with node-negative cancers that were, again, smaller than 3 centimeters, again, after lumpectomy. 84% had hormone-sensitive breast cancers. The median age on this trial was 61 years old. And the ipsilateral breast tumor relapse rate at 8 years was 3% versus 2.8. So with that being so close and such a large number of women, they were able to show equal efficacy. Research on partial breast radiation has gone beyond, just proving that it's safe and efficacious. In my group, Rocky Mountain Cancer Centers, specifically my colleagues in Denver, including Dr. Charles Leonard in in Littleton, Dr. Dennis Carter in Aurora, and Kathy Howell in Littleton, to name a few, have explored some of the technical aspects of external beam delivery for partial breast radiation. And they studied whether or not intensity modulated radiation specifically can achieve even better results than 3-dimensional treatment. So this was a phase 2 trial of 105 patients treated with high precision partial breast radiation. And they found that minimizing the chest wall volume was important for minimizing chest wall discomfort ultimately. And this is useful information for radiation oncologists. These researchers have published a 4-year update, and their data showed that the IMRT technique could reduce dose to normal structures such as lung and heart to rather important organs. So in conclusion, hypofractionation, whether whole breast or partial breast in early stage breast cancer, is as good as conventional treatment, and possibly a slight inkling that it may be better for women who meet the criteria. We've shown equivalent local control and survival. We have very robust scientific data, including multiple randomized controlled trials to support either hypofractionation or accelerated partial breast radiotherapy. This is more convenient to patients and hopefully can provide more necessary care to more patients. Any questions?
Thank you so much, Dr. Weeks. That was amazing.
Thanks.
I'm going to ask you if you would stop sharing your screen so we can see your face a little bit better. There you are. Okay, so anyone watching live, if you have any questions, please feel free to put them into the comments section within Facebook. We had a couple of questions that I kind of thought of, and I've had patients ask in the past. So one of them said, my surgeon said I would only need like 5 days of radiation, but you're recommending 20. What's the reasoning?
Sure, great question. So your radiation oncologist will likely be the very most familiar with the important guidelines for who exactly is a candidate for which fractionation scheme. And as we saw, the criteria for the fastest 5-day treatment is actually a little stricter than for other forms of hypofractionation. And there are many pathologic nuances and age criteria and so forth. And so that does happen sometimes where women have this expectation set of a 5-day course, and ultimately they don't meet the criteria and are going to undergo the 20 fraction course instead, or that's the recommended course. So really the radiation oncologist will be able to spend time with you explaining in your unique circumstances what's best for your individual situation.
That makes sense. Thank you. So out of curiosity, is it just as safe to have 20 days of radiation as it is the 5? What's the difference other than convenience, I guess, would be the question.
So the 20 is almost a little slower and gentler, if you will, and it is just as safe. The efficacy and safety of both of those methods of hypofractionation have been extensively studied, and the cosmetic outcome as well as side effects are equal between them.
Okay. Can men be eligible for this type of radiation?
So that is a good question. So men were not included in trials. And so generally we use scientific evidence to back up what we're doing. And for men, the tried and true standard is still our 5.5 to 6.5 weeks.
Great. Can you be too young to have radiation?
So great question. So as far as it relates to hypofractionation in the breast, there is no age cutoff anymore for hypofractionation of the whole breast. And that again is our 3 to 4 week treatment course. So any age in the accelerated partial breast 5 fraction course, the age cutoff is really for age 50 and above. And for women 40 to 49, there is less data to support its use, though again can be considered on an individual basis depending on circumstances and willing to maybe take a bit of an increased risk.
Okay, all right. And then I know you had said that this is for patients who've had lumpectomies and stuff like that. What about that patient who says, hey, I've had a mastectomy, am I still eligible for this?
Okay, good question. So this is still under investigation, but it's a great question actually that researchers are currently asking. There's some data, some Chinese randomized data, actually where they looked at close to 1,000 or more women undergoing very similar fractionation, 15 treatments after mastectomy, and found fairly equal efficacy and disease-free survival and local control. And then recently there was actually a meta-analysis. What that means is researchers combined results of 25 different smaller trials for a total of over 4,000 women. And they similarly showed no difference in toxicity. Again, the two things we look at, side effects and does it work? And so again, they've shown no difference. So I think we may be trending in that direction. What the authors of the meta-analysis concluded, published by the way this year, they concluded that really we need bigger randomized controlled trials, just a bit more data before we can uniformly recommend it. There are 2 ongoing trials right now looking at this. So we may have an answer in the next 5 to 10 years or so, maybe sooner.
Well, we'll cross our fingers.
Right.
I don't see any other questions in the comments section, so I think we will say thank you very much, Dr. Weeks. This has been so informative. Thank you for your time and your expertise, and really appreciate everything you provide for our patients.
You're welcome. My pleasure.